Okay. I think we get into a, let's say, more discussion type of session. And Pierre, you are the first one that you should speak about what trials can our cooperative group suggest in high-risk MDS. I think we are very eager to know.
Hello, do you see my slides? Okay, so I mean, we really already started the discussion. So, oops. Sorry. Yeah. So we really started the discussion. I mean, we are the groups here, and so we could consider clinical trials either in first line or in relapse refractory patients. So in first line, we've talked about it. I mean, it's a bit difficult to have at the moment, at the present time, academic trials because companies are all registering their drug versus azacitidine alone, and we have no doublet, which could be a reference. So it's a bit, I mean, it's a bit difficult, and I'm afraid overall we'll have to wait for results of those phase 3 trials. But as soon as something is positive, potentially suggests the addition of a drug to the reference doublet, and we may go fast and perhaps faster than companies. And as Lionel stressed, the fact that we can sign various contracts may help because companies always take, I mean, they want to register the drug and they you know, they don't bother whether a triplet is better than the doublet. What they want is their drug to be used. So it could be interesting, but we have really so far no hints. All what we know is that if for example, venetoclax becomes the reference drug in addition to azacitidine, as it is for AML, a third drug will have to be non-myelosuppressive because otherwise this is not going to be manageable. Now, there could be some subset where we may do some academic work, and I've just given the example of the TP53 mutated subset, like, for example, adding ATO, which we're trying to do. There could be, well, there are no obvious other drugs. There could be also subsets. I mean, IDH1, IDH2, this is being explored by Lionel and Marie, but then we could subsequently perhaps upfront consider combinations in the future. So those are small subsets where we may potentially do what companies do not do, at least in the field of MDS, because what we can do is extend what some companies are doing in AML to MDS as soon as possible. That's many possibilities, but so far in practice, very difficult. So in this first line part. So we've thought a lot about it. We've talked a lot about it. We've had video conferences, including with the all groups, various groups, and it's not obvious. So perhaps the relapse refractory may be also to consider, and I know it's been considered. Just a few principles. First, those patients are not all similar, and so we should stratify them. Well, we know there's these scores like the NASHA score and others. There is also the fact that primarily resistant and relapsing patients may not be the same. Also, we should definitely avoid patients who evolve too fast. And for example, Norbert Wey at the GFM led several trials in second-line treatment of an add-on drug, and quite a few patients never could be treated because they increased their blast rapidly. And that's the problem with those second-line treatments, is that if you take the intention to treat, then you may have false negative results. And this is, for example, typically what occurred with enazidenib in relapsing AML, which eventually led to no registration in Europe, and, for example, stopping this patient support, this patient name program we had in France, which was quite beneficial. So it's a big issue if we don't take care, and we see those patients. So we have to be careful. And I will also tend that to say that patients who are candidates to transplant are a very specific population. population, because this is a population where it is clear that some patients can be cured and have prolonged outcomes. So if you mix those patients with others, then you're going to have false results, and you can of course try to censor when patients are transplanted, but that's always spurious. So this being said, suggestions, well, we have the add-on trials with HMAs, and we all are using in some patients azacitidine plus venetoclax. We know it gives a lot of blast clearances, but few CRs, very prolonged CRs. So it can be interesting before a transplant, but I think we all have the same experience, very long, very prolonged myelosuppression. Now, I know a trial is being discussed now of AZTEC 727 plus sabatolimab. That will be an interesting experience, and other add-on approaches may be considered in this setting. Well, yeah. And now intensive chemotherapy, as I said before, we have at the GFM a CPX trial of 2 days of CPX instead of the classical 3-day regimen. Well, it's myelosuppressive. It could be useful before a transplant. I'm not sure it could be useful in other patients. So outside of bridging to transplant, it may be disputable. Now, we also have the BST-03, which is, as I said, a prodrug of RSE, probably also the same type of indication, because it's not obvious to have intensive chemotherapy after HMA failure. And with other drugs now, the problem is using single agents. And in this situation, but imetelstat may be interesting, and there may be other agents. So, I mean, this is a difficult situation here, but I know there is at least one project, which is AZTEC 727 plus sabatolimab, which certainly is interesting to consider. And for the rest, the idea, my impression is that the add-on strategy with HMAs is currently the less bad, I would say, because single agent, except if it's targeted like IDH2, IDH1, of course, is not obvious in such a situation, except for a phase 1, an early phase 2, but that's not something for a multi-country trial. So that was really all I had to say. It's nothing obvious, but yeah. Perhaps someone wants to say a few words about the AZTEC sabatolimab trial?
I don't know, well, Uwe, you wanted to say something, or shall I just introduce
I think you Valeria, or?
Yeah. So the idea is that we do not have options for relapsed refractory patients with high-risk MDS after HMAs. And you know that there have been several trials, sponsored or non-sponsored, that failed, like the guadecytabine, rigosertib, you name it. So the companies are quite reluctant to establish studies in this setting. On the other hand, these patients do not have any real option. This is why we got together and thought of combining sabatolimab, the anti-TIM3 antibody by Novartis, with the oral decitabine AZTEC 727, because we think that this could be a real good option. And I think that we are in the finalization of the protocol. The idea is to include patients who have failed azacitidine and treat them and evaluate response and also other parameters. That's a good example of what we were discussing. So just be together and propose to 2 companies our ideas and have them accepted, of course, with the general agreement with the European group. I think that is a good platform to start working in this way. And I am sure that will be the first one of other attempts we will make.
And I think, Valeria, this study, I mean, it's basically in status nascendi, as we would say in Latin. So it is not all agreed on. I think if our Spanish friends would like to join and would like to be part of it, I think there's still a moment, as I understood. So I think this would be a great
absolutely
opportunity to study HLA failure patients together.
Absolutely. Of course, it's an open, it's not finalized. It's going to be finalized, hopefully, in a few months, but it's open. And as I mentioned, it's an European trial. So, of course, it's something we would like to share.
And I think, if I may comment, I think this proposal that was from the EMSCO, but that was also support from Novartis, highly reflects the way the company are nowadays thinking of the treatment of MDS. They don't want to get too much involved because so many trials have failed in the past. So they are still interested, but they don't want to get too much involved, at least personally, in the development of the clinical trial. And I think this is the case for second-line therapy, of course, but maybe it will become a reality also in first-line therapy, because given the negative results of the pivonidostat, and if the Verona trial is not positive, I don't know. But at the end, most of the pharmaceutical company will be quite reluctant to involve themselves, at least, in the development of their drugs. But still, there is an interest. So it might be a good opportunity for the group to have those drugs, to conduct trial, and to have the development of those drugs in our hand.
Absolutely, but what I would like to say, and what was I hinted at before, is that the companies are not going into losing fields, because as I mentioned, this is a very difficult setting of patients. But if we have a good design, we can, let's say, risk more as an academic group, because we are not so linked to the development of drugs. So I think that to find a way in difficult subgroups and setting is very important.
I think I'm David from Spain. Of course, we will be happy to collaborate in this trial. And as you mentioned, companies are somehow reluctant to get involved in some trials in MDS, and the PEVO trial will not help, because this is I don't know what number of trial failing in MDS, but I think that we can also be of help in this setting, trying to help in the design of clinical trials, because we are the people treating the patient, and we really know that some of the trials perhaps are, at least in part, failing because of the design is not fully correct, and that perhaps we can try to find some populations, more homogeneous populations, in which we can try to develop next studies, instead of including all the MDS patients, higher risk MDS patients, into one trial, and at the end of the day failing to show any kind of benefit.
Are there other comments on this or ideas? Pierre?
No.
Okay, then I think that we will come back to these points in the future. And I didn't understand, Marie-Robin had some overlap with other meetings, but I'm not sure she's here. Otherwise, Uwe, you want to, and David, you want to speak about the attitude before allo stem cell transplant in MDS. Can we share this attitude and have a common strategy?
David, I don't have slides. I just have.
Oh, No, but nobody is supposed to have slides. I think the last session is going to be just our ideas and confrontation and discussion.
I know.
So one of you should start.
Well, I can go first. I think that if MDS is difficult, patients with MDS and transplant candidate are perhaps even more difficult. The first thing I think I want to say is that I'm not sure I agree with Pierre regarding that those patients who are transplant eligible should not be included in this kind of clinical trial, because otherwise we will lose the opportunity to improve response rate in patients who are potentially curable. So I think that I would say that from my point of view, the clinical trials need to be need to include these patients who are candidate for transplant, but the number of patients to the sample size should be corrected, taking into account that some patients may become a transplant candidate after initial treatment. Is somehow common in patients between 65 and 75 years old, that once you start the treatment, they can have some response, even improve in the ECOG performance status, and then you consider to drive them to transplant. So
David, I was speaking, excuse me, I was speaking of patients for second-line treatment or
only for
beyond.
second line.
Of course,
okay.
No, I was not speaking of first-line patients.
Okay, perfect.
How common is it, Pierre, to do it? I mean, second line, what kind of patients are you referring to? Like HLA failure, or what is?
Yes, I mean, you know, there are some 65 or so patients, you know, they have a normal karyotype, they know they can have a certain, well, duration of response with azacitidine, and they don't want to be transplanted up front. That occurs regularly, I think, because they, obviously after 65, the risk of course, of dying, we all know, is not negligible. So, yeah.
I mean, transplant studies are, at least I can speak for Germany, are, from a bureaucratic approach, are the worst. So, because because the transplant is part of the approach, and then you have to go to PI and to these authorities, which I'm not saying it's impossible, but it requires a budget, it requires a lot of bureaucracy. But I think if we would agree on a, let's say, SOP-like approach in our countries, where we, let's say, we just write a proposal as a guideline how we approach, which could mean to facilitate induction chemo or other approaches. I think we could generate some data, some real life data, which would allow to omit a little bit a clinical trial and just to collect data at the same time, because this is a rare patient population. It's important to get some prospective data, but I think a trial also requires a lot of resources, and I think outside a pharmaceutical company is sponsoring it, it will be hard to obtain.
Yeah, but Uwe, you're right. But how do you write this sort of recommendation and guidelines? You should really base on evidence. And not always we have strong evidence, as you know very well, in a sense or another. So we should get together and have a consensus of several people, because it's quite hard. You know that there are papers showing having some evidence and other not consistent. So to have a unique approach would be a big work to accomplish. Marie, do you have comments on this?
Hello.
Hello, welcome back.
Yes, that's just a little bit complicated for me because I didn't follow the discussion.
Okay, no,
we just started on transplant, approaches before transplant, Marie.
Sorry.
Approach before transplant.
Yes,
Yeah.
yes, how to approach a common strategy.
That's true that we still have many questions about that. And this last month, we focused on the question about the pre-transplant therapy, and especially the room on for upfront transplantation in MDS patients. We have this national project, maybe which can achieve some hospital budget. We'll see a PHP budget, but we don't have the answer for that yet. So for me, I don't still have the answer regarding the pre-graft treatment. But with the new drugs and the better quality of the responses, that's still, I think, an answer to know what is the room of this different therapy. We are more and more using the combination therapy, I think, as all of you, especially hypomethylating agents with venetoclax, and it seems that maybe we can shorten the delay between the first cycle and the transplantation, because maybe the response to this treatment is quicker.
Yeah. But Marie, if I can ask you, are you treating patients with high-risk MDS with azacitidine and venetoclax before therapy? Because we cannot do it. So, I mean, are you doing it within a clinical trial, or are you doing routinely?
Off-label, off-label.
Off-label.
Off-label, yes.
We are also doing it in some patients as compassionate use, as venetoclax is somehow easy to obtain once you have the approval from the hospital, and there are many hospitals doing the combination before transplant.
Yeah, no, but what another thing is that, Marie, you were not there, but I showed the data that Elena Crisa developed on the real percentage of patients who achieve a response that can undergo transplant even if they are eligible, and it's a very, very minor percentage. Now, improving the pre-transplant therapy, improving the times can be really increasing the number of patients that can really undergo transplant. So that is a very important point to discuss.
Yes, but again, if we would like to improve the probability to be transplanted, there is also this possibility to transplant them upfront, especially if the patient has a related donor, which can be HLA match or haplo. That's also possible.
Yeah, sure.
And in terms of strategy, I can't remember if it's David or Uwe who said that a trial, especially a randomized trial, is not easy to conduct. And in the end, I wonder if it should not be guidelines and patients included in a registry also, so that we have a denominator, and because they are in a registry, we can publish, because it's always difficult. I mean, we know Vyxeos is not going to work in complex karyotypes. We know it. We know that azacitidine azacitidine often works very slowly, so we attempted by azacitidine plus venetoclax, and sometimes upfront if the transplant can be done rapidly, but we'll never solve the issue. The idea is indeed to have a good denominator, as you did in Italy. I mean, you start from a certain number of patients and you know who is transplanted and how. And after that, I mean, we clearly know that complex karyotypes do not respond to chemo and respond better to hypomethylating agents. And potentially that if blasts increase slowly, we can try to transplant upfront, provided, as Marie says, we have a related donor, sibling or haplo. So. But if the patients are well studied, if they are on a registry, then we have true information. And
yeah, but that's why Elena started this study, because we are always talking about patients who have to be transplanted. We never know exactly the numbers and the reason why they are so in such a small and reduced number in the end.
Perhaps EMSCO can be a platform to try to give some guidance. I'm not sure it's that easy, because for example, I have some doubts regarding direct transplant using haplo, because you can find an unrelated donor in 60–70% of the cases, and you need 2–3 months to perform the unrelated donor search, and I'm not convinced regarding a haplo role in the MDS specific population. So perhaps we can give some options, and as Pierre mentioned, register this kind of patients, and in some time, probably in collaboration with EBMT, have some responses to the questions.
Although EBMT sees the ones who are transplanted, not the ones before. You mean the donor search? Okay.
Yeah. Yes, at the end, the EBMT has, as you mentioned, the data after the transplant, but in the EBMT database, there are they lack a lot of the pre-transplant data.
Yeah, exactly.
Marie knows it's very difficult to have those data, and perhaps a collaboration can be of help trying to answer this question of which is the best approach, because we are moving from chemo then to azacitidine, and now we are talking about venetoclax plus azacitidine, but at the end of the day, we don't know if this is really working or not. And if we are not doing some effort, we will have the same question in 5 years without any answer.
Yes, absolutely true.
But probably if we do it in the setting of EBMT, we should conduct a prospective observational study and be sure to have the denominator, because that's the main question of the probability to receive the transplantation. So the problem I can see will be the regulatory issues if we try to conduct this trial with EBMT, and the budget, which can be very high.
Other comments on this long-standing issue of transplant?
No, I mean the idea of something observational is indeed that it reduces budget. So I think in the end, because there will be no industrial sponsors, at least, and for such a study, they obviously are not interested. And we tried with Jazz, they were not interested. We tried with AbbVie, they were not interested. So I think at the end of the day, you know, it's the idea of a registry, or you know.
Yeah, but we fluctuated from the proposal of a study to the proposal of a recommendation and consensus. So what is your idea for the near future?
Well, my view is that reaching a consensus on this point will be absolutely impossible, because our vision in this issue is very, very different. And well, Uwe and the German transplant group has recently published in the Journal of Clinical Oncology a very relevant study showing that if you are going to use azacitidine before the transplant, you should be very careful and try to limit the number of cycles of azacitidine, because it is dangerous for the patients. And my view is that any other combination, including other potential hematologic with hematological toxicity, such as venetoclax, will, let's say, not improve, but in contrast will decrease the probability of the patients to reach the transplant and have the probability of the likelihood of getting cured. My view is, personally, is that all MDS patients, independent of blast count, mutational analysis and cytogenetics, should go to transplant upfront without any treatment before the transplant. And this is opposite to the view of many of you.
Okay, Guillermo, do you want to say something about your ideas of EMSCO as a central point and a central entity for Europe and as a European MDS group? Because you wrote it in the chat. You are muted. Okay.
No. Yes, I did. I think that in this sense that EMSCO should become a professional team, as Uwe has stressed previously, and for this we should, let's say, start formal cooperation agreements between all of us to set the governance body and establishing very transparent rules for cooperation. And we need, obviously, a professional team for doing all the paperwork and day by day work, and in this sense, this could increase the probability that the visibility, the progress, and the sustainability of EMSCO will be improving in the future. And I think that this is not the topic of today, but we could, let's say, set up a call to discuss all these issues, because I think they are very relevant for our future. I don't know, Uwe, what do you think about it?
Yeah. It's not the topic of today, but I think that is related also to what we were discussing for transplant. Uwe.
Yeah, no, I mean, I liked Guillermo's comment. It's impossible to get an agreement today, which is true, but still the discussion is very valid. I'm really dreaming of a satellite structure for Europe, where each country has a let's say respective coordinator for these kind of efforts in a professional structure, and they work together, and they can also help us with protocol writing and all these things. I think we should really develop this kind of professional structure, still leaving each country independent with regards to clinical studies and registries and whatever, but to take advantage of such a professional structure in the future, I think is crucial for our clinical activities. This is, I'm absolutely sure about that. And I think we could even get some European funding for this kind of idea, because this is also what the European Union and Horizon 2020 and so on, I think what they want us to develop, because what I learned from BfArM and other authorities in Germany is that the structure, how to approve clinical trials in the future, will probably rely on real life data as well. So let's say a company, for instance, is doing a pivotal trial in a rare subtype of patients, phase 2 study with, let's say, targeted treatment and the response rate of XYZ. So that the drug will be conditionally approved. However, it requires a validation in a kind of registry phase 3, phase 4 a program in taking advantage of large study groups. And I think we could start also cooperative clinical trials with pharmaceutical companies to validate findings from early company-sponsored clinical trials. But I think this requires a more professional network within our groups. I think that's, and it relates not only to transplant, of course, it relates to everything.
Yeah, and I'm sorry I have to cut this discussion, but for the sake of time, we have to give space to Michaela, because she's going to suggest more and better translational studies within the EMSCO. So please, Michaela.
Thank you, Valeria. Can you see my screen? It's okay? Okay, so the subject was, can we suggest common translational research projects? So just a general strategy, we all know that we begin from a clinical observation or a translational observation of a basic observation. And then we want to understand what's happened. And then we move to the validation of what we understand from the initial observation. So that's a concept. We have several past achievements, and I would like to highlight some, but of course not all. And for instance, the contribution of translational research to basic knowledge. And I would like to stress this paper from InMedio in collaboration with several, including Uwe and a member of his team and some French too, showing that AXL inhibition in macrophages stimulates leukemia, anti-host versus leukemia immunity. And I consider this work derived from the initial studies of the BGB 324 that have been performed in a clinical trial. So indeed, it was very, very contributive, and I forget Katarina is part of this work too. And this is also a contribution of basic knowledge to translational research. And this is a work from Eric with many collaborators, showing that there is a mere 150 TET3 pathway that regulates monocyte subsets. And this explains what he described before and what became the signature of CMML. And finally, the clinical research is probably also contributive to translational and vice versa. In this paper from Valeria with collaborators already highlighted, that showing that we could have a molecular signature of response to decitabine, even if it is mentioned now that it could be a different signature in the Dakota trial, but we don't know exactly at the moment. So just to say that we have indeed a collaboration between researchers and clinicians. And this is also an example coming from my lab, and showing that we had an initial observation looking at RNA-seq and the splicing event in MDS with SF3B1 mutation. We try to understand what happened with this splicing variant of erythroferron, and we quantify a different molecule in the serum of different cohort, in French cohort from the clinical trial of the GFM. And finally, we validate that there was an increased level of erythroferron that is related to the presence of this splicing variant. So it's an example of collaboration between the three countries. So I just remind you, but it's not necessary, the clinical aims we have: a preemptive action on the transition from the clonal hematopoiesis to MDS. We want to cure low-risk MDS cytopenias, try to make a preemptive action against leukemia evolution, and to cure high-risk MDS. And what the translational research domains bring to us: the biomarkers of prognosis, the theranostic biomarkers, markers also of disease pathophysiology, and this is very important to me, and the mechanism of action of the drugs that help sometimes the repositioning. And we want now to have indicators for combined therapies and indicators for preemptive interventions. So for that, in all our countries, we have competencies by the association and the close relationship between clinicians, biologists, and basic scientists and bankers. We have the resources, the local biobanks, the national biobanks, the registries, the data managers, and the clinical research assistants. And we have a lot of platforms, mainly because our hospitals are mainly associated to research institutes. So we have a lot of tools, and there was some tools presented in the 3 talks in the previous session. And we, of course, have widely in the different countries, DNA sequencing, RNA sequencing, single cell analysis, the target sequencing I talked previously from Raphael Sixon's lab. We have also developed spatial transcriptomics that could be useful to analyze what we do not do at the moment, the bone marrow of patients, but it could be very interesting if we look at what's happened now in solid tumors and the contribution of these special techniques to that, the proteomics, the proteogenomics, and all the techniques to study the microenvironment contexture, the 2D and 3D organoids. And of course, many of them have access to mice models, including the PDX and the PDX with human ossicle on the back of the mice. So I think it's time to try to set up a translational research platform. And I would like to first start by proposing a multinational translational research committee. And I think it's go in the same ways that we discussed about the clinical trial just before. So to be more reactive, to be informed of the forthcoming clinical trials, to be assigned to set up biological studies, to negotiate specific fundings. And this has been discussed too, to apply for European funding. But also we can make application to national cause with transnational cooperation strategy and apply to grant from industry. What is urgent, and Eric said that before, is to make the banking, and probably we should make this banking on site for serum and plasma. But banking is always necessary, even outside the clinical trials. And I would like to stress the necessity for an open access EMSCO database, including all the patients enrolled in the clinical trials with all their clinical and biological data. Because I do think, I think we all think that future developments will be helped by sharing big data, especially in rare disease and consequently in MDS and CMML. And of course, there is an example of that with the EU MDS registry, the Harmony initiative. Just a word about the UNCAN initiative, UNCAN for Understand Cancer. this is a European initiative that is supported by the National Cancer Institute and Research Institute. For France, it's ANCA and INSERM. And Eric is responsible for the coordination of the project that is running for 1 year before being effective, I think. And this ICAN EU is made of a core consortium with several countries, advisory partners, and also consulting partners and stakeholders, meaning most of these associations, which are indicated here. And what is the objective is to set up a virtual European institute dedicated to translational and basic research with the fair European principle, which is fundable, accessible, interoperable, and reusable. So we expect, and they expect, a federated cancer data hub that could be readdressed in all types of cancer to make challenge and to challenge the different treatment strategies, including prevention, early diagnosis, age-driven biology, therapeutic resistance, and survivorship. And this challenge will put some more data in this data hub. So shouldn't we prepare to participate in this hub with our current database and also our current initiative? And I will stop with that and ask for your comments on this proposal. Thank you.
Thank you very much, Michaela. I don't quite understand because you said that this UNCAN project has already started.
No.
So you...
Not already, it is only the application and asking for the support of Europe, and in the next year, all the work will to set up this database, and of course it will take time to become efficient. But indeed, this database, this hub, could be made of different database we have in the different group, in the different pathologies, and probably it should be interesting to for people involved in MDS to participate in that initiative and to share the data. In the, I think we can make a comparison with the TCGA.
Okay. Are there any comments?
Michaela, excellent.
Yes.
Excellent presentation. I'm a big fan of you. I think you know this.
Thank you, Uwe.
Okay, but just a question. So this is this an initiative where you are looking for still members and for, I mean, or is it already a set up, a closed club, or is this, I mean, can you just explain to us? I mean, for instance, if we would like to participate here from Leipzig or other sites, could they join? Is there some funding? Again, funding is not the issue, but just to give a little bit the principles and the background, this would be nice.
Okay, if I understand correctly, and sorry, Eric is not present, but he should explain this better than me. It is a national initiative, so you are virtually involved, Uwe, because your country is involved in the core of this initiative, and probably this starts from your national cancer institute if you have something like our ANCA. I don't know exactly, but of course there is a large place made to the more frequent cancer like solid tumors, of course, colon cancer and so on. But indeed, hematology is well represented in that field, and we are all virtually in it. But we will be asked to participate more actively and to participate through probably the database and to create this hub that is the way to share the data. But at the moment, what we can do in EMSCO and what is my proposal is to try to make this hub within our community and after to put it in this larger one.
what would be of importance maybe would be to create a group within the EMSCO dedicated to translational research.
Yeah.
Because we have different projects. We've been contacted, some of us have been contacted by Matteo for his project and so on too. But we might have a group within the EMSCO dedicated to that with regular meetings, you know, to share the experience, the funding, not sharing the funding, by the way, but sharing maybe the samples and so on. So it might be of interest to have this group.
I think Michaela.
Yes, Guillermo, I was expecting your comments.
No, I think it's an excellent initiative, and as I understand, this initiative is devoted to every kind of cancer,
yeah,
including solid tumor and hematological malignancies.
Yeah.
For this project, you should need a very high level of funding. Should it be possible for you to tell us to which call of the European Union have you applied?
I can't answer this question, but I will ask Eric maybe to present this, because he's chairing this initiative, and I've not this information, because we are not always talking of work at home. I don't know everything.
So you don't know. These are secrets.
But I will ask him to answer your question and to send you an email.
But Michaela, to bring it to the ground, maybe, would you be interested to chair such a committee within this group, and to also, you know, I mean, just to also harmonize the way we biobank material? I think that's also very important, that we harmonize these kind of things in the future. Also, the way we allocate samples, the way we annotate samples. I mean, these are, at the end of the day, I mean, the diversity will increase, and we will treat in 10 years AZTEC1, RUNX1 double mutated lower risk MDS with a platelet count of less than 50. You know what I mean? So this, and you want to understand the biology and need samples. So I think such a group may be an interesting platform. I think it should not be too formal, but just to have a little SOP, which is harmonized between our group and could be also sent to other participating sites in the future, also when little small clinical trials are performed, just to say, if you, at the moment, this is cutting edge biobanking, this is how we do it. We do FICO, we do plasma at -20, we do XYZ. Samples should not be older than 24 hours. So these kind of things should help to really annotate the samples and also to do reliable translational research on these samples in the future.
Mm-hmm. Yes, of course, Uwe, it should be my pleasure, but indeed we have a lot of things to learn from each other, and I was very pleased to collaborate with your team to set up the biological studies of the LUS+, because there is a great professional in your team, and indeed it was really a pleasure, and I think we have to share the protocols, how to do this and that, and indeed I need volunteers to do the job with me, and I'm not sure I will chair that for a long time, but I can start if you want, and I will be very pleased if people can join me and say, yes, I would like to participate, and I will not say any names, but I have names in my head. Of course.
Well, no, I think thank you very much also for the feedback to Katharina Soldan, I think, who was in contact with you. She's a hardworking postdoc, and I think try to professionalize these kind of things. Maybe she could let's say be the one who can send the emails, communicate, so take the burden of communication from your shoulders, and just organize maybe a first meeting where you discuss with all the people interested, and I think just have this platform within our collaborative group would be an asset. And this is also, I mean, we also have to see each other in competition a little bit to our American friends, where this kind of procedures are not very well harmonized in the majority of the cases. So this could be a real asset. And if we start it now, I think it's a great investment in the next 5 years.
Yeah, thank you very much for the proposal. Thank you.
And for this purpose, what I think is essential is to have a link between all the biological information you can achieve and the clinical information, including treatment and so on, to be enabled not only to dissect the basis for a particular disease or mutation, but also to know what is its relevance in real life. Mm-hmm. Very good idea, Michaela.
Thank you.
Thank you.
Thank you, Valeria.
Thank you very much. If there are no other comments, I think we can talk about Harmony projects now and how we are leading them. Pierre, do you want to take the lead and say some words? And then Andrea.
Well, I don't know. I mean, the Harmony is the idea of collecting the large numbers of patients in each disease and therefore to be able to analyze things more in depth. In the case of MDS, we are 3 co-chairs, Valeria, Andrea, and myself, and we are collecting, I mean, many patient data has been collected, and there are currently some projects. One is the outcome of MDS and CMML, also treated with HMAs, and therefore trying to see if with larger patient numbers we're able to determine prognostic factors, etc., and how long we should treat patients, and quite a few scientific questions. There's a second project which is on the discontinuation of lenalidomide in DER5Q patients. And there is also a proposal, and I think Anne-Sophie will speak about it later, of artificial intelligence and taking taking advantage of the large patient number. And this is open to other projects, of course. Guillermo is one of the leaders at the overall of Harmony, and as I said, Valeria, Andrea, and myself are just on the MDS part. So far, the project that's most advanced is that on HMAs, and data is collected, and so we should in the next few months potentially have a good analysis, an interesting analysis. But it's open once again to new projects. Valeria or Andrea or Guillermo, you probably want to add something?
Well, I would like to offer some data. We have already in our big database data on 12,000 MDS patients, very well annotated patients, and we are expecting in very few months to have data coming from Latin America, also from Austria, and also from other countries and centers. And the idea is to start with these projects, but as Pierre has mentioned, everyone who become a member of Harmony Alliance, is up to, let's say, propose their ideas on a particular research project. And I think this is an open consortium, and we feel that in the near future we will be able to better characterize what are the main problems that we have for getting better treatments for patients, and also to fasten the availability of new drugs, including one suggestion that we are currently working with the European Medicine Agency, that is the use case, let's say, to use the Harmony database at let's say a tool to use in new clinical trials that will not need randomization. Let's say the data could be used for, let's say, establishing the standard of care, the results, the outcomes with the standard of care with any particular drug, and then compare the results in this database with the results in a particular clinical trial with a single arm, and this obviously will fasten the availability to have new drugs in a shorter time ready for use in patients. This is some of the objectives, and we are starting with these three projects that already Pierre has mentioned, but we have a lot of ideas for the future.
Just to go back to what Pierre was saying, I think it's very important to have all this data in the Harmony platform. At present, for instance, for the HMA project, we have 3,300 cases. Now, not all of these cases will have molecular data, but as you may well understand, this is a huge number. So even only with clinical data, we should be able to say something and to conclude something in terms of prediction of response, or anyway, type of patients who are treated. I think it's the highest number of patients that has ever been collected and put together. So we don't know what will be the outcome of the analysis. And again, we don't know how many of these patients will have complete molecular data, but for all of them, we have clinical and cytogenetics data. And I think that is 10 times higher than the patients included in the randomized clinical trial. And I think that it's going to be then validated by, as Guillermo said, by the data coming from South America and other countries. So as we stand now, we have more than 3,000 cases. I think it's very important. Only with HMAs, sorry. With us, and to be precise, with azacitidine.
True with azacitidine.
Yeah,
I think it's only 85 with decitidine, unfortunately.
Yeah. But you know, in Europe, azacitidine is approved, and decitidine is not approved for MDS. So it's not a surprise that there are so few patients like this. That would be a surprise otherwise. So 3,300 patients for azacitidine. I think it's really a very good number. Andrea.
Yeah, I also think it's a very good number, and maybe it's good that we have mostly azacitidine data, because many studies that did this before, they looked at combinations of patients treated with aza and decitidine, and analyze them together. So I think it's good to have a relatively uniformly treated group. So it mustn't be bad.
Yeah. And harmony, it's something that is bringing us together again and shows the necessity to work all in cooperation and be as inclusive as possible. So Fernando Ramos is telling us that he agrees with the idea of a very strong EMSCO, and I think it's really as a central professional structure. I think it's really very, very important, and harmony has shown us that we can really achieve a lot if we put all our data together. And the translational ideas, it's also as important as the clinical participation in clinical trials.
And we also had the chance to already present you our guide project. And of course, we would be very happy to work together into our projects and to collaborate with Harmony.
Yeah, indeed. Are there any other comments on harmony? Otherwise, we leave Anna space for discussion. Anna, you want to share you have slides, I suppose.
Yes. So hopefully you can see my slides.
We can.
Perfect.
Hello, everybody. My name is Sophie KUBASCH from the Department of Hematology, Cellular Therapy and Hemophysiology here at University Hospital Leipzig. And I'm very happy to present and discuss, of course, with you some common artificial intelligence projects in MDS. At first, I want to introduce you to our recently founded junior research group, AI in Hematology. This is our first picture taken last year, and we are very happy to present you today our first projects within the next slides. If you talk about the application of AI in MDS, I think, or I hope everybody knows that hopefully the future will be bright in the field of the application of AI in MDS, because there's such a lot of fields where we think that AI can be very useful and helpful for us as physicians. A very important part will be, of course, screening and diagnosis, and of course also prognosis and risk stratification. Here we are already working in a EU-funded project called Genomic4R. Also, a very important field will be the prediction of clinical course and patient's destination for the application of AI. And if you talk about our daily business, of course, clinical decision support is something we have to do every day. And we think this is also a very important part for the application of AI. And since last year, we are working on a data-driven clinical decision support system called KITE. And I want to go into more detail within the next slides. And if you talk about hematology, we always talk about trial design and drug development. We think that this will also be an important part for the application of AI to get maybe our drug approval process more faster. Let's start with a few examples in the field of screening and diagnosis. Maybe you already heard about that in a non-hematology setting, there are already some AI-based medical products licensed, like in the mammography field, when an AI-based system works as a pre-screen to identify women at low risk whose mammograms required less or no radiological review. Something similar we think about in the cytomorphology setting in our MDS field. There, possibly in the future, an AI-based system is able to identify dysplasia, helping to get a more accurate and more faster diagnosis of our MDS patients. Another very important part will be the application of AI in the field of prognosis and risk stratification. Here, as I already told you, we are working together in a Genome for All project since last year. It's an European Union Horizon 2020 funded project. And within this core, we are working on three diseases, on the myelodysplastic, multiple myeloma, and the sickle cell disease. And within these three diseases, we are working together on a faster diagnosis, on AI-based algorithm for early identification of high-risk individuals. We are also working together to get a faster prognosis by the development of predicting algorithm for more accurate insights on disease development. And a very important part will be also the clinical algorithm development to aid decision-making in risk stratification to get a more faster treatment decision for our patients. This is a big consortium we are working together within 23 organizations from 8 EU countries. Here's just an oversight about all of the partners, and we are very happy to be part of it. Let's go now to another very important field of our daily business. This is the personalized treatment decisions for our MDS patients. Since last year, we are working on the KITE project, a data-driven clinical decision support system for patients with MDS. You can now, of course, ask why we need such a knowledge-driven AI-based platform for therapy decision support in our hematology field. Of course, since the last 20 years, we as the physicians have decided for the right treatment decision for our patients, but I think also the last talks today showed us that treatment decision is becoming more and more complex in our field, and therefore we think that an AI-based therapy decision tool will be very important to get the right and perfect match treatment decision for our patients in the future. And in the KITE project, we are already working for around a year now, and we decided to focus on 3 diseases. This is the myelodysplastic syndromes, acute myeloid leukemia, which we are developing together with the University Hospital Dresden colleagues. And the third one is multiple myeloma, which we are developing together with the colleagues at University Hospital Jena. I think all of us know that, as I already told, that the treatment is getting more and more complex. A lot of new markers are just guiding us away to a more personalized treatment decision. At the end, we hope that our AI-based system will implement the clinical data, the cytogenetic data, immunological data, and of course molecular, possibly also the initial chip data in the system. And at the end, not only we as physicians at big university hospitals, but also very small outpatient centers are able to use KITE to get a personalized AI-based risk stratification and also a personalized treatment decision guiding the way for the best treatment decision for their patient with hopefully the highest clinical efficacy, but also the lowest side effects. And for this purpose, we are working on KITE. Since last year, we developed already 3 disease models. This is just an overview about the MDS disease models here. You can see a lot of small features, like here the bone marrow data, clinical data, this cytogenetic data, and also some features about molecular data. Everything is processed into this disease model, and at the end, hopefully, a personalized treatment decision will guide us the way for our patients. Which data is necessary to be implemented into our KITE system? Of course, clinical guidelines will be the main part. Here in Germany, we are working with Oncopedia, where all of the clinical guidelines are written down. Another very important part is the registry data. Here we are working with a few, or maybe the most important MDS, AML, myeloma registries in Germany. And the third part will be the clinical study results. Here we're working together with various companies asking for their phase 2 and 3 original data to be implemented in our guide system. And another very innovative part of our project is an AI-based PubMed matching, which we are developing together with Merantix, the company in Berlin. The aim here is that after entering all of the clinical data of our patients into guide, there will be an AI-based PubMed matching showing us, for us as a physician, maybe matching phase 2 and 3 clinical data with more innovative treatment options, and at the end, maybe also some small case reports, just opening the window for more personalized treatment options. What is our guide roadmap? So we already entered in the modeling and development phase now, will be followed by the validation phase, and at the end, we hope that we can approve guide as a medical device in 2023. If you are interested in more information, you can always look at our guide homepage, guide.health, and there's also a white paper with more technical details. You're invited to download it there. And now I want to thank you for your attention, and I'm always open for questions. Thank you so much.
Thank you very much, and Sophie, wonderful projects. I think Guillermo has some comments.
Well, no, we have initial conversations with Anne-Sophie and the guide project,
right?
Because the aims of both initiatives are almost the same, and I think most of the partners in each initiative are common to both projects. What we need to establish is the way to put in common the data. As I understand, you are using a federated way, no? I'm right? And in Harmony, we are using let's say a data lake, and this was because the possibility to run a federated transfer of data was not available when Harmony was created.
Mm-hmm.
We have to think in which could be the way to say cooperate very closely, because I think that this cooperation would enlarge a lot the potential for reaching meaningful conclusions regarding the outcomes, the management of patients with MDS. It's very, very nice project.
Thank you so much. And we know already that, of course, the guide system will only work if the data quality is good enough, and we have a lot of training data from our patients. So it would be very helpful to cooperate in this area. Thank you.
I think that this is the way to go now, because we have huge amounts of data and we need to have super expert and artificial intelligence algorithm and machine learning to get the results out of it.
Thank you.
Anyone else wants to comment on this? I think we should, integrate Genome for All and Kite and all these projects in one unique thread, so to speak. Not to disperse too much the energy and the data as well.
Absolutely, yeah. And are there also some annual Harmony meetings where maybe some potential cooperators can come together? Is this something you are already having in mind?
You know, some of the person working on Genome for All are the same working in the Harmony platform. So I think that this will help for sure to analyze better.
We are going to have our 2021 General Assembly of the Harmony Alliance in November 17 and 18 in The Hague at the EHA, let's say, venue, and I would very much appreciate if you can join virtually or live, because obviously we are going to have this kind of hybrid meetings, because not many people, especially from the pharmaceutical companies, are still able to travel, and so I will do my best, and I will talk with our communication manager at the EHA to let's say to send to you all the material and that you need to be present in our General Assembly, and being able to present this project in the particular meeting of devoted to MDS.
Perfect. So we are always happy to join, hopefully in person next year. Yeah.
Okay. I think we are coming at the end. So maybe we should have some words of closure. We're all together again. Pierre, do you want to?
No, I don't know. As we are in Nice, I mean, the words of closure
should
be by Thomas Clouseau. Should be by Thomas Clouseau. No? Where are you, Thomas?
Thomas.
Yeah. Hello.
Hello.
Yeah. So yeah, you are welcome in Nice next year. Of course.
Summertime, Thomas? Summer or?
In Nice, the weather is good all the time, so you can come when you want.
Always summer.
But if you want in summer, but I think the aim on the EMSCO meeting is to have some presentation. Maybe in summer you won't be with us.
Yeah, I think we should agree on a date pretty soon then, Thomas. That's
we didn't discuss for the moment about the date, but I think we have to discuss all together to be sure there is no other meeting in other country in the same time. But I think we would like to organize maybe at the end of September or at the beginning of October, because you want during the summer, and we have a long summer in Nice. So
there is the only meeting I can think of at the end of September next year is Soho in Houston. If it's going to be in person, I don't know, but.
And you, Uwe, you have something at the beginning of October? No?
No, honestly, even if I have something, I would rather go to Nice than there. So we only have to keep in mind that at the moment, we had this MDS colloquium before the pandemic in Berlin every 2 years. So the idea was to do it in beginning of November, 4th and 5th of November. This European MDS colloquium, where I think many of you are participated already. So maybe the beginning of October is maybe a good idea for Nice, but we could discuss this offline maybe and make some suggestions from your side. Maybe I think also the venue is important because you have to book it, and so this is also something which defines the date rather than when we can do it. Maybe
Sylvie Cuvillier is here and will tell us, yes, will advise us, yes.
And we all come.
I mean, we definitely come.
But I think it's better at the end of September, because in October there is the I think the German hematology meeting. Then the second week is the Spanish hematology meeting, and it's much more difficult to be there. But in the last 2 weeks of September, I think there are few and less relevant meetings.
Okay. I found this meeting now, I mean, honestly, this meeting today was really very good exchange. I found it so important that we meet. And I think we should prioritize also ourselves for this meeting, and maybe give rather virtual speaks at talks at other meetings, because it's so important that we meet and stay together as a European platform. I think if we don't go to Soho 1 year, I mean, we will not die, definitely.
No, absolutely.
And needed.
Okay. So thanks a lot to everyone then.
Thank you to everybody. Have a nice evening.
Yes, you too.
Goodbye.
Thank you.
Bye.
So bye-bye.
See you soon.
Bye.
Bye.